Hi guys, good afternoon. Unfortunately, seems that Facebook Live is not feasible. So I guess from now on, we'll just have to record the videos, and then I'll just send them to you during the class. So if you have any questions, you can message me through our group in Messenger. All right. So for this lecture, we are going to tackle on ischemic heart disease. Okay, so let me just share to you the slide. All right, so here we go. I hope that by now you would have um, seen or viewed the YouTube video on coronary circulation. So for you to better understand how the heart is being perfused. Okay, so your ischemic heart disease, as from the uh, words themselves, ischemic. So this is a disease of an interrupted blood supply, okay, of the heart. All right, and it has, or it falls into two large groups of diseases, mainly your stable coronary artery disease, which we will refer from now on as your SCAD. And of course, you have your acute coronary syndrome or your ACS. Okay, it's a common term in the clinics uh, that you call diseases such as these as coronary artery disease, but it's important for you to know which ones are categorized under your SCAD and your ACS because mainly, although their mechanisms are almost the same, there are just subtle differences. Their management will differ, okay? And the prognosis of a patient will having each of the diseases in these categories will have a different outcome, right? So under your stable coronary artery disease, this is mainly your stable angina pectoris. And then under your acute coronary syndrome, you have subgroups. You have non-ST segment elevation ACS, which contains your unstable angina, and your non-ST segment elevation myocardial infarction, or your NSTEMI. Okay, another classification under ACS is your ST segment elevation MI. Okay, it's important that your STEMI, your STEMI is a separate entity in your classification under ACS because it is the one with the poorest outcome and it requires a specific medical attention and surgical attention. All right. Now let's try to discuss each of these diseases one by one. Now, let's begin with stable coronary artery disease. How does this come about? All right. So, by the definition itself, it says that it is an inadequate supply of blood and oxygen to a portion of the myocardium, which is the heart walls, causing inadequate perfusion, which is termed as ischemia, and supplied by an involved coronary artery. So, what are the important things that you should note in this pathogenesis? So, what's involved is the blood supply and your coronary arteries. The blood supply to the heart is supplied by your coronary arteries, and you have different coronary arteries supplying various areas of the heart as well. Okay, so just go back to your coronary circulation video so that you would know which ones are your left anterior descending, which one is your left circumflex, and then your right descending arteries, coronary arteries. But we will discuss them a little later. All right. Now for your stable coronary artery disease, mainly your um, stable angina pectoris, it is usually induced by your stress and exercise as well as emotion. So what does that mean? So when a person has this disease, has stable angina pectoris, the chest pain that is felt in this disease may be triggered by what? Stress, kapag under stress yung tao, or for example, nag-exercise siya, or there are severe emotions, just like for example, nag-break sila ng boyfriend niya. Okay? So, masama ang loob niya. And suddenly, nagka-chest pain siya. Okay. But what are the characteristics of your chest pains under your angina pectoris? Well, we will be discussing that a little later. First, what is the cause of your stable angina pectoris? What's mainly involved is your atherosclerotic disease. What do you mean by atherosclerotic disease? Kapag merong deposits ng lipids in your blood vessels, it makes those blood vessels narrower. Okay, so when the blood vessels, just like for example this one, um, becomes narrower due to lipid deposits, so the blood going through that blood vessel is a bit impeded. Okay, it's like for example, syempre kapag may konting barado, yung hose, let's say for example, yung hose ng tubig, di ba, hindi masyado nakakadaan yung tubig. Tama? Okay? And tumataas yung pressure. It's very much the same as that. So, when the blood supply is diminished, when you are already on a stressful situation, or you are doing exercise, or there are extremes of emotions, your heart needs more blood. Okay. Pero since clogged or partially occluded yung arteries mo ng lipid depositions, hindi masyadong nakakarating ngayon yung dugo doon sa heart. And that causes the main symptom, which is chest pain. Okay, hindi nakakarating ng maayos yung dugo doon sa puso kasi nga merong lipid depositions doon sa coronary arteries. So that is the main reason for your angina pectoris. All right. What are the different risk factors? Who are those persons who are susceptible to these kinds of disease? Mainly, you have the people who are obese. Sino pa? Yung mga insulin resistant, mayroong insulin resistance, and your type 2 diabetes mellitus. Bakit? Bakit related ang obesity and diabetes mellitus dun sa uh, angina pectoris? So when you are obese, there are many circulating lipids in your blood. Okay. And if mas marami ang lipid na nagsisirculate doon sa blood mo, ibig sabihin, there is a higher tendency for them to deposit in your blood vessels, which will include your coronary arteries. Alright. So, kapag maraming taba, nagde-deposit dun sa coronary artery, partially occluded yung coronary artery, nagkakaroon ka ng angina. The same thing is true with your diabetes mellitus. In your diabetes mellitus, you have an increased blood glucose levels. And it is thought that these blood glucose levels also contribute to your vessel damage. Nadadamage yung blood vessels mo, nagkakaroon siya ng repair, and then nagnanarrow yung lumen kasi yung mga na-damage na lumen ng blood vessel ninyo, kina-cover up niya until such time na narrow na yung dinadaanan ng dugo. Okay. Now, we go to the clinical manifestations of your angina pectoris, mainly your chronic stable angina pectoris. So these are the things that you should know. All right? Okay, so usually ang description is the patient is a man who is 50 years old or a woman who is more than 60, which complains of chest discomfort. Okay, paano dinedescribe yung chest discomfort? It is described as heaviness, pressure, squeezing, or choking. Alright. So yung chest pain nila, kakaiba. Minsan, ang sinasabi sa'yo ng pasyente mo, if sa Ilocano, nadagsan. Okay. It is common for people to characterize the chest pain as dull and heaviness on the chest. Yung parang dinadaganan ng mabigat na bagay dun sa chest. Okay. It is not. Okay, remember this. If in the chest pain, you ask the patient to point at the location where the chest pain is, if yung pasyente, kayang-kaya niyang ituro kung nasaan yung masakit doon sa chest, kaya ituro, eto masakit. Okay, tapos pinindot mo yung chest. Sabi niya, oh, dyan dok, dyan dok. Okay. Is it angina pectoris? No. Most probably, that is your costochondritis. Yung muscles ng chest mo yung masakit. Kasi nare-reproduce mo yung pain and natuturo mo ng maayos kung nasaan. The chest pain in your angina pectoris is vague. Nasa loob. Kasi nasa puso yung sakit. Nasa puso yung problem. So, nasa loob yung description niya. It's vague, it's dull, it's heaviness. Okay, so that's the description. Basta tatandaan nyo, heaviness, pressure, squeezing, or choking. All right. Another important characteristic of the chest pain is that it occurs in a crescendo manner. So what does that mean? Tumataas yung sakit and then nawawala ulit. Okay? So crescendo, pataas, pababa. Okay, meron yung time na nagbi-build up yung pain and it reaches to a certain point na masakit and then later on, it wanes. Okay, so that is your crescendo pattern. Now, in your chronic stable angina, it is also important to note the duration. Kasi pain ito, di ba? How do you assess pain? You assess pain by knowing your OPQRST, isn't it? So onset, P. What are your precipitating predisposing factors? Q, quality. R, radiation. S, other signs and symptoms that are associated with the condition. And T is your timing. Now, you have your duration. It is important in angina pectoris or in any chest pain to ask for the duration. So for this specific disease, it usually lasts around 2 to 5 minutes lang. Okay, so it means that after that time, 2 to 5 minutes, nawawala na. And it coincides with your the crescendo pattern. Kasi sabi ko nga, nagbi-build up, nawawala. In 5 minutes time, dapat wala na siya. Alright. So what is it related to? Ano yung mga precipitating factors? Sabi natin kanina, stress and physical exertion or your exercise or extremes of emotions. Alright. For example, like exercise, nag-marathon siya ng 5 kilometers. After a while, masakit na yung chest. Ganon. Alright. Where does it radiate? Well, in the clinical setting, halos pare-parehas sila ng radiation. Okay? However, it is characteristic for this disease to radiate on both the shoulders and arms. Hindi lang sa chest, na feel niya rin sa shoulder portions. Okay, right or left, but mostly sa left, syempre. Okay, now, what are your relieving factors? In 5 to 10 minutes time, after ng sakit, dapat wala na siya with the use of your nitroglycerin. This is an important diagnostic parameter in your angina pectoris. Kasi yung mga angina pectoris, usually sila yung mga nare-relieve ng sublingual nitroglycerin. However, as you go on along the line sa mga acute coronary syndromes, hindi na sila masyadong nagre-respond dito. Okay, so a while ago, we have described the chest pain, the classic chest pain in your angina pectoris. And that is what we call the Levin's sign. Okay, ano yung Levin's sign ng ginagawa ng pasyente? Yung fist niya, closed or clenched fist, nakalagay dun sa puso. Okay? Dapat yung fist niya nasa puso. Okay, ganun ang mukha ng mga may angina pectoris. Or even, yung mga yung mga na-atake sa puso. Masakit yung chest, nakalagay yung kamay doon sa chest area with a closed fist. That is your Levin's sign. All right. Now, before we go to the physical examination, it's important for us to understand, hindi natin na-discuss kanina, for us to understand how your lipids go to your blood vessels. All right. So, balikan lang natin itong image na ito. Let us try to explain it first. before we proceed to the physical examination findings. All right. So from the food that we eat, especially fatty foods, um, we digest that in your stomach, and then eventually, yung food kasi na kinakain natin, meron siyang components just like your protein, fats, and carbohydrates. Okay. So carbohydrates, usually yung mga sugar, sweets. Okay. So your fats, nadadigest dun sa uh, stomach, and then on your intestines, they get emulsified. Okay. So after they get emulsified in your, or emulsified meaning na breakdown sila. Yung, what breaks down your lipids? Okay, so you have your bile salts and other pancreatic enzymes. So after na break down yung lipids into smaller particles, they can now be delivered to your liver. Okay, they can be delivered to your liver via your chylomicrons. Okay, so pupunta na ngayon siya sa liver. And in the liver will now use those broken down lipids in order to synthesize your lipoproteins. In your liver, it generates different kinds of lipoproteins, all of which have different effects on the body. Alright? So, ano ang kailangan nyo lang tandaan dun sa mga lipoproteins na sinasabi ko? Okay. So, you have your VLDLs, LDLs, HDLs. VLDLs for very, very low density lipoproteins. You also have your LDLs, which is your low density lipoprotein, and your HDL, which is high density lipoproteins. Okay. So, sino ang bad cholesterol sa kanila at sino ang good cholesterol? Okay. So, your bad cholesterols are your low density lipoproteins. Saan sila galing? Galing sila sa very low density lipoproteins. Nabre-breakdown lang sila into LDLs and then later on transported into your tissues. Okay. So, pinaliit lang siya na VLDLs. Alright. Bakit siya tinawag na bad cholesterol? They are called bad cholesterol kasi sila yung mga nagde-deposit doon sa blood vessels natin and then your tissues. So, pag nag-deposit sila sa blood vessels natin, okay, naka-cover up siya, okay, and then it results in the formation of your plaque. Okay, ito yung plaque. Okay, ano ang contents ng plaque? Siyempre, yung lipid core, you have your foam cells, you have your inflammatory cells as well. Alright, tapos meron siyang fibrous cap. Medyo matigas-tigas na cap para hindi siya mag-breakdown ng madali. Okay, however, what's more involved in your atherothrombotic events are those lipid or are those plaques na mas maliit kasi yung mga mas maliliit mas prone sila na mabuksan yung fibrous cap nila and then mag-spill yung contents and then they will initiate now your primary hemostasis. So kapag nagkaroon ng primary hemostasis, which will be explained later on when we go to your ACS. Sila yung nagda-block. But what's important for you to know it is that your in this slide for now is that it is your LDLs that deposit into your blood vessels. Okay? So, sino naman yung sinasabi nating good cholesterol? It is your HDLs, high-density lipoproteins. Bakit? Kasi your high-density lipoproteins will now return yung iba pang cholesterol na nagamit papunta ulit sa liver para mag-synthesize ng ibang lipoproteins. Okay. So, yung excess, dinedeliver niya ulit sa liver. Kasi yung excess, di ba, sinabi natin na yun yung nagde-deposit sa blood vessels. Okay, so siya ngayon yung chaperone na kumukuha ng excess at pinabalik na lang sa liver instead na ma-deposit sa blood vessels. That's why he is good. Okay, tandaan, LDL, bad cholesterol, HDL, good cholesterol. Alright, so now moving on with the physical examination findings of your chronic stable angina. You have your paano mo ba ina-assess? Ano yung mga titignan mo muna doon sa pasyente natin? Okay, first, you evaluate for anemia. Bakit? Siyempre, kapag anemic yung tao, mababa yung RBCs niya, mababa yung hemoglobin, and you know that your hemoglobin contains your oxygen. So mababang oxygen, walang masyadong oxygen na pumupunta sa tissues ninyo, including your heart, you may feel your chest pain. So you have to rule out anemia. Okay, another thing, hypertension. Okay, it's very important kasi narrowed yung blood vessels. The same thing, limited or mababa ang perfusion ng heart. Okay, or other valvular heart diseases or arrhythmias. Alright, baka naman meron palang lesion doon sa puso kaya nagkakaroon siya ng chest pain or nagkakaroon ng arrhythmia, malapit na mamatay. For example, nagkaroon ng uh, electrolyte imbalance. Just like for example, yung hyperkalemia, tapos nagkaroon ng arrhythmia, kaya siya may chest pain. Okay, that is deadly. Alright, so these are the things na kailangan mong i-rule out first whenever you see a patient who is complaining of chest pain. All right, what are the other things that you should obtain? You should take the blood pressure, the heart rate and rhythm, as well as the BMI. The BMI is in relation, of course, to your obesity, which is common sa mga merong chronic stable angina. All right, so what is the primary management for your chronic stable angina? Of course, kasi uh, this is just a stable condition naman, stable naman, kaya nga stable angina, prevention is key in the management. You have your diet and exercise in order to manage obesity. Smoking cessation, bakit? Anong relationship ng smoking cessation doon sa angina pectoris? Your chemicals in your smoke, in your cigarette, when they get deposited in your blood vessels, they can incite damage in the lumen. So sabi natin, kapag may damage ang lumen, nire-repair ng katawan. Hanggang sa kakapal yung lumen at magiging narrow na yung blood flow. Narrow na yung lumen at bababa ang blood flow, I mean. Okay. And you should also control the other risk factors which we have mentioned a while ago. All right. Ano yung mga gamot na pwede natin ibigay? What are the medications? There are 3 drugs for usage that are used in your chronic stable angina, which will optimally reduce your thrombotic events. What do we say? What do we mean when we say thrombotic event? Balik lang tayo din sa picture. Ito, this is the plaque, right? The atherosclerotic plaque. Now, pag nabutas yan, nag-spill yung contents, anong gagawin ng blood vessel? Parang sugat lang. Pag nasugat ka, anong gagawin niya? Maglalagay ng mga platelets para ayusin yung sugat. Okay, and it will initiate your primary hemostasis. Magkakaroon ng platelet plug, kakapal yan para ayusin niya. Okay, the same thing happens in your thrombotic event. Kaya sinabing thrombotic event because you develop thrombus or yung plug doon sa sugat. Okay, parang sugat lang din kasi ang nangyayari dyan. Okay, so dadagdag hanggang sa mag-couple sila ng madami at ma-occlude yung buong blood vessel. Imbes na, for example, ito na nga sa picture. Ito. For example, this is your whole lumen. Imbes na ito lang yung narrowed portion, kapag nagkaroon ka ng thrombotic event, maaring yung buong blood vessel ma-occlude. Okay. So what are these medications? You have your aspirin, which is an antiplatelet. You have your ACE inhibitors to manage your hypertension. And then you have your statins. Statins, simvastatin, atorvastatin. What are these for? They will lower your blood lipids. Okay, kasi nga central to the cause of your angina pectoris is your hypercholesterolemia, that which may be present in your obesity. Okay, ano pa yung mga ibang medications na binibigay natin sa mga merong chronic stable angina? You give your nitrates. Sabi natin, dapat kapag binigyan mo siya ng nitrates, nagiging okay yung chest pain. What does it do? It dilates your blood vessels, which is your coronary vessels. Okay? What else? Side effects lang kasi niya is yung headache. Sumasakit yung ulo. Okay, another drug your beta blocker. So anong ginagawa ng beta blocker? Hinihinaan niya yung heart rate ng puso. Okay, heart rate ng puso. No. Hinihinaan niya yung heart rate. Bakit kailangan hinaan yung heart rate? Kasi the more that the heart pumps, the more na nag-e-effort yung heart, it needs more oxygen. It needs more oxygen, therefore it needs more blood supply. So if you lessen the heart rate, lesser oxygen is required, lesser blood supply is needed. Okay. Calcium channel blockers, well, this is for your coronary artery vasodilation para lumaki yung lumen size and it creates a better blood flow. Okay. So, mastery alert, ito yung sinasabi ko kanina about your good and bad cholesterol. Okay, it's important. It's an important thing for you to know. All right. Now, we have here another case. We will now proceed. We're done with your chronic stable angina. Now, we are going to proceed with your patients with acute coronary syndrome. All right. So, we have here an index case of a 52-year-old male who happens to be a smoker as well as a hypertensive individual who now has a complaint of substernal chest pain, which radiates to the right arm. Okay. Tapos, meron siyang diaphoresis. Diaphoresis, pinagpapawisan. Okay. So the chest pain persisted despite taking sublingual nitrates. Okay. On physical examination, his blood pressure is normal and heart rate of 90 BPM. So normal pa naman. All right. So let's dissect the condition of the patient. You have here a chest pain in a hypertensive and a smoker. Okay, risk factors ng ischemic heart disease. Tama? Okay. Pero, meron siyang diaphoresis. Sweats. Okay. Nakita ba natin yun sa chronic stable angina? Hindi, di ba? Okay. What else? Kahit uminom siya ng nitrates, hindi na gumaling yung chest pain. Okay. Another important thing to note, di ba? Kasi yung chronic stable angina, nagre-respond sa nitrates. Okay. So now, what is your most likely diagnosis? You have your ACS. ACS lang muna ngayon kasi wala ka pang pina-perform na kahit na anong laboratories and diagnostics. Okay? So, ACS muna. Acute coronary syndrome. And then you would consider STEMI versus unSTEMI versus unstable angina. Nauna ang STEMI kasi siya yung pinaka-worst and siya yung pinaka nagre-require ng immediate attention. Right. So, ano ang gagawin mo? Ano ang pinakaunang gagawin mo? Obtain an ECG. Okay. Bakit importante ang ECG? Well, it differentiates now your STEMI from your NSTEMI. Okay. Ano pa yung ibang lab exams na pwede mong gawin para ma-differentiate mo itong tatlo? Okay? You can order for your cardiac biomarkers. Okay. What are your cardiac biomarkers? These are your troponin E, T, troponin I, your CKMB. Okay. Yun yung mga pinaka-common na in-order natin. Alright. What else? What is the most common underlying pathophysiology? Tatandaan nyo to. Plaque rupture. Okay? With a superimposed non-occlusive thrombus. So yung plaque na sinasabi natin kanina, pumutok na. And it initiated a thrombotic event. Alright, now, going deeper into your acute coronary syndrome, we are going to discuss first your non-ST segment elevation ACS. Non-ST segment elevation STS, we have two, di ba? Ano yung isa? Yung unstable angina. And the next one is non-ST elevation MI. The pathogenesis is basically the same. Anong sabi dito? Imbalance of oxygen supply and demand. Okay. Resulting from a partially occluding thrombus from a disrupted thrombotic coronary plaque or an eroded coronary artery epithelium. Alright. Anong tatandaan nyo dito? There is a partially occluding thrombus. Okay. That differentiates it from your ST elevation MI. Okay. Tatandaan, partially occluding. Hindi pa buong circumference ng blood vessel mo ang parado. Meron pang konti. Meron pang konti na nakakalusot. Okay, yun ang tatandaan. Sa non-ST segment elevation ACS, meron pang konting dugo na nakakaabot, na umaabot dun sa puso. Okay. Now, by definition, your unstable angina first has your characteristic chest pain, just like yung nauna na diniscuss natin, or ischemic discomfort with at least isa dito sa mga babanggitin natin. It occurs at rest or with minimal exertion and lasting more than 10 minutes. Okay. So let's say for example, yung chest pain more than 10 minutes na, okay, you can start considering that it is unstable angina. Pero pag less than 10 minutes, anong sabi natin? Stable angina. Okay, what else? Severe and of new onset yung chest pain. So within the past 4 to 6 weeks lang, merong biglang sakit na lang, biglang nananakit yung chest. Okay, that's why it's called an acute condition kasi biglaan within the prior 4 to 6 weeks. Okay, and the last thing, occurs with a crescendo pattern. Okay, and it is more severe than the previous episodes. Okay, yung kanina, yung stable angina, crescendo decrescendo, lumalala hanggang sa nawawala. Ito, lumalala ng lumalala. Okay, any of the three, you can use it to diagnose your unstable angina. Okay, how about your NSTEMI? Ano lang? It has the clinical features of your unstable angina. Ganito din. Ganito din. Pero anong idadagdag mo? Ang idadagdag mo lang is meron kang elevated biomarkers. Okay. So, eto, clue nyo na to para ma-answeran nyo yung activity later on. So, for your unstable angina, negative ang biomarkers mo. Ano ba yung biomarkers? Sabi natin kanina. Biomarkers is, yun yung mga substances na pinoproduce ng cardiac muscle mo kapag nagkakaroon ng necrosis or kapag namamatay yung ibang parts ng heart. Okay, yung muscle niya. So kapag, di ba, kapag walang dugo or occluded yung dugo, yung blood vessel na nagko-contain ng dugo na nagsusupply din sa heart, walang oxygen na pumupunta dun sa distal portions ng heart, yung mga sinusupply ng blood vessel. So when there is no blood supply, there is no oxygen. So what happens if there's no oxygen? Mamamatay yung portion ng heart na yon. Kapag namamatay, it's what we call necrosis. Okay, when we produce necrosis, we produce substances out of the necrosed part, which is now your biomarkers. Now, ang tinitignan mo ngayon sa cardiac biomarkers is if nag-occur na nga yung necrosis. Alright, so with that in mind, you will now know that your unstable angina has no necrosis yet kasi wala nga siyang cardiac biomarkers. Now, what differentiates NSTEMI from unstable angina is that it has now elevated cardiac biomarkers. Pero technically, parehas sila ng presentation. Tama? Okay, review. Quick recall. NSTEMI, positive cardiac biomarkers. Unstable angina, negative cardiac biomarkers. Okay. Paano yung chest pain ng unstable angina? More than 10 minutes, sudden onset, and crescendo pattern. How about your NSTEMI? Paano yung chest pain? Parehas lang. More than 10 minutes, sudden onset, and crescendo pattern. Okay. Yun. So, na-specify na natin yung mga definitions nila and specifics in order for you to be able to diagnose your ACS. All right. So what are the other things that you should know? Meron kang dyspnea, nahirapang huminga, yung pasyente, nagkakaroon ng cold sweats, pinagpapawisan kahit hindi naman mainit. This is very common. And once you've seen a patient just like this, masakit ang chest, tapos pinagpapawisan kahit hindi naman mainit, magtaka ka na. That will already be a sign for you to refer this individual to the hospital or to a doctor. Okay. Anxiety and restlessness. Okay, parang meron siyang impending doom. Parang mamamatay na yung feeling. Okay, what are the signs? These are the physical examination findings that you will see. You have your pale or cool skin. You have your mabilis ang heart rate, sinus tachycardia. Meron yung added heart sounds, your S3 and S4. Pwede kang makarinig ng crackles, and you have your hypertension. And those are ominous signs. Alright, so gaya ng sabi natin, central to the pathogenesis of your acute coronary syndrome is the rupture of your vulnerable plaque. Okay, so ito yung blood vessels natin, ito yung plaque na sinasabi natin. Alright, so yung contents niya, lipids, you have your platelets, you have nagka-cover doon, then you have your fibrous cap. Alright, kapag na-erode ito, paano ba yung erosion na sinasabi natin? This is your blood vessel, and syempre, dumadaan ang dugo dyan. Alright, pag yung pressure ng dugo, o yung dugo, tumatama dito sa elevation na to, dito sa parang bukol, for example, yan, ito yung blood flow. Yun, daan ng daan yung blood. Yung iba, tumatama dito, di ba? So, tumatama dito, pataas ulit. Okay, di ba nga, pag nabubunggo yung isang bagay, pwedeng, anong mangyari? Pwedeng masugatan. Ganon din yung plaque. Yung pagtama ng dugo, dahil may pressure din yung flow ng blood, syempre, these parts are vulnerable to rupture. So, eto yung part na yan. So, kapag nag-rupture yan, magkakaroon ng thrombus. Aayusin ng katawan. Lalagyan niya ng madaming platelet, yung primary hemostasis na sinasabi natin. Nag-create siya ng what we call thrombus. Okay. Recall. Anong una? Plaque rupture. Plaque rupture, after plaque rupture, thrombus formation. Yung thrombus formation, that is a normal action of your body sa sugat. Just like sa sugat din. Okay. So, syempre, tinatapalan niya yung sugat para hindi masyadong mag-bleed. Ganon din yung ginagawa dito. Pero, ang difference nila, yung thrombus kasi, madami yan. Okay, so anong ginagawa niya? Magpa-pile up siya ng magpa-pile up dyan. And then, anong mangyayari sa blood vessels? Syempre, nananaro yung lumen. Masikip na yung dinadaanan ng dugo. And that causes your chest pain. Okay. So, anong gagawin natin? Sabi natin, we have your 12-lead ECGs, your electrocardiogram, and your cardiac biomarkers. Why do we do ECG? In order for us to know characteristic changes in the electrical system of the heart, in order for us to know if merong mga ischemic areas, necrotic areas, just like that, which will be seen a little later when we discuss your ST elevation MI. Okay, now what is the main difference between your management in acute coronary syndrome and your stable angina? Basically, dinadagdagan mo lang yung management. Dinadagdagan mo lang. Halos parehas lahat. Pero habang lumalala yung sakit, diba, hindi malala masyado yung stable angina. Habang lumalala siya, nagiging acute coronary syndrome, nagdadagdag ka ngayon ng management mo. Okay, so what are the things that you do? Central to the management is your non-pharmacologic. Importante din to. Ano yung mga yun? Bed rest, stool softeners, and oxygen support. Bakit mo binebed rest yung pasyente? When you exert effort or energy, mas maraming oxygen ang kinakailangan ng puso mo. So, pagod na nga siya, may sakit na nga yung puso, papagurin mo pa. So, kailangan niya ulit ng additional na blood. Eh, wala nang blood. Eh, di mas mamamatay. Isipin mo na lang yun. Pag yung pagod, yung may sakit, bibigyan mo pa ng trabaho, kaya ba niya? Hindi, di ba? So, pagpapahingayin mo muna yung puso. That's why you need your bed rest. Alright. Stool softener. Anong connect? Anong connect ng stool softener dun sa yung pagtae, dun sa sakit sa puso? Ang layo naman ng puwet dun sa puso, Dok. Well, when isn't it that when you strain, kapag nagbawas ka, when you go to the CR, nagbawas ka, if you strain, ganon, you will now exert pressure dun sa puso. Okay, try nyo. Punta kayo sa CR, tignan natin. Pwede ka bang mag-CR or magbawas nang hindi ka nagsistrain? Hindi, di ba? Okay? So, the straining process creates more pressure in the heart. So, you will now want to decrease any effort in the heart, any additional effort in the heart para mapagpahinga siya kasi may sakit yung puso. That's why you soften the stools para mas madaling mailabas ng pasyente yung tae niya. Inevitable naman natatae yung pasyente, di ba? What you just have to do is to soften the stools para hindi siya masyadong mag-strain. Okay, so yun yung concept doon. And the third thing is your oxygen support. Di ba nga, konti ang oxygen na pumapasok dun sa heart, konti na nga. So, kailangan mong dagdagan in order to at least elevate your oxygen levels in your blood. Okay, para kahit yung pakoonting pumupunta dun sa puso mo, at least marami silang oxygen na dala. Okay. Next, anti-ischemic therapy. Well, nasabi na natin kanina to. Nitrates, beta blockers, and calcium. Oh, bakit nagna-nitrates ka pa? Nagna-nitrates ka pa dun. Sabi mo kanina, Dok, na hindi naman sila nagre-respond sa nitrates. Well, you use your nitrates para ma-expand din yung blood vessel kasi. Alright? Pero since this disease entity composes of blood vessels that are only partially occluded, kailangan mo pa rin i-dilate yung blood vessel na yun para mas may dugo na pumunta or dumaloy. Alright, you have your beta blockers, calcium channel blockers, these are your antihypertensives, and you have your morphine. Morphine, bakit ka magbibigay ng morphine? Diba? Kapag yung chest pain niya masyadong malala, kailangan mong i-relieve. Kapag hindi na ma-manage ng mga usual lang na pain relievers, well, magbibigay ka ng opioid, yung mas malakas. You will now give your morphine. Alright. Actually, by mnemonic kami. Meron kaming mnemonic in the management of your acute coronary syndrome. Ano yung mnemonic na yon? Lagay na natin dito. Okay. We have the mnemonic which is your MONA. Ano yung MONA? M, morphine. O, oxygen. N, nitrates. And A is your aspirin. Okay, sila yung mga staple management for your acute coronary syndrome. Sila yung mga importante mong tatandaan na binibigay. Ulitin natin, MONA, morphine, oxygen, nitrates, and your aspirin. Okay. Standard medications, you should manage your risk factors, obesity, and the likes. Statins, antiplatelets, your aspirin. Bakit ka nagbibigay ng antiplatelet? Yung antiplatelet kasi, tinithin out niyo ang blood. Parang kung sa Ilocano, padaroyon na digidara. So, when the blood is less thicker, mas madali siyang mag-flow dun sa blood vessel na occluded. Okay, so that's the point. Para mas makadaloy yung dugo. Alright, you have your anticoagulants. Kasi, bakit? Sabi natin, di ba, nai-initiate yung coagulation cascade dun sa pag-rupture ng plaque, kaya nagkakaroon ng thrombus. So, anong gagawin mo ngayon? I-prevent mo yung further na pag-propagate ng thrombus. That's why you give your anticoagulants, which now dampens your body's response to the plaque rupture. All right. And secondary prevention, which now tackles the risk factors or modifies your risk factors, which is the same as your stable coronary artery disease. Okay, now we're finished with your non-ST elevation ACS. Now we go to your last part, which is your ST elevation myocardial infarction. Ito na yung atake sa puso. Okay, ito na yung stroke sa puso. Okay, anong etiopathogenesis? Sabi, acute plaque fracture pa rin, just like your non-ST elevation. It occurs when coronary blood flow decreases abruptly after a thrombotic occlusion. Meron pa ring thrombotic event, atherothrombotic event of a coronary artery previously affected by atherosclerosis. Okay. Pero kung yung NSTEMI and your unstable angina is partial occlusion ang pathogenesis, dito sa ST elevation MI, there is full blockade. Baradong-barado na yung blood vessel mo, yung coronary arteries mo. So wala ni katiting na dugo na dumadating dun sa distal portions ng puso. Okay, what are the manifestations? Well, similar as non-ST elevation. Okay, meron kang clinical features of your chest pain. And you have your elevated cardiac biomarkers. Okay, so damage yung puso, nagre-release ng biomarkers, nagkakaroon ka ng chest pain. Pero ano ang dinadagdag mo? Ano yung tinitignan mo, importanteng tignan mo para ma-diagnose mo na ST elevation? Well, it's in the name itself. ST elevation. Doon sa ECG mo, dapat meron kang ST segment elevation. Alright, so what is the ST segment ba? Doon ano ba yung ST segment? Okay, so this is your typical ECG reading. Pero abnormal na to abnormal na to. Dapat ganito yung mukha niya. Ganyan. Pero yung T-wave dapat baliktad. Yun yung normal. Okay, this is your, wait, highlight natin. This one, this is your P. Ito, yung una na hump, that is P. Q, this is your Q before the spike. Q, pero pathologic ang Q. Kapag meron siya, malamang natake na yan dati. So, in normal people, wala siyang Q wave. Okay, pero basta alam nyo kung nasa yung Q. R, yun yung tip ng spike. R. Pagbaba niya, S. And then ito yung last na hump is your T wave. So those waves correspond to different portions of your action potential in your heart muscle. Well, you can read on ECG reading. You can search for videos on ECG reading, but we will not tackle that for now dito sa subject natin na to. Okay, what's important for you to know in your ST segment elevation is that ito yung ST segment. Ito. Kung nasaan yung S tsaka yung T. So, kung ano yung nasa gitna niyan, yun yung ST segment. Alright, ito siya. Kapag meron kang injury, tumataas yung ST segment. Tingnan nyo, malaki ang pagkakaiba neto tsaka neto. Mas mataas to, di ba? Ito yung isoelectric line mo, mas mataas yung ST segment mo. That is now ST segment elevation. And what your ST segment elevation indicates is that it is a zone of injury. Well, not factually na zone of injury, zone of infarct na yun actually eh. Yung Q waves, yes, infarct, pero basta ST segment elevation infarction, meron kang mataas to. You produce your Q waves in a matter of later on after kang na-attack sa puso. So, kapag nakita ka ng Q wave, baka ilang araw na yan na-atake. Okay? So, anong nakikita mo muna on the acute event? ST segment elevation. Okay. So, it signifies that part of the heart is already damaged. Okay. So, paano natin maintindihan yung damage dun sa puso? Well, it's important for you to know first what are the layers of the heart and how it is perfused. Na-discuss na yan kanina dun sa coronary arteries, coronary circulation. But let's try to discuss it a bit more. So yung outermost part, kung yung puso mo, ito, puso mo to. Pag puso mo, hinati natin ng coronal section. Ito makikita mo sa loob. Okay, so this is your left ventricle and this is your right ventricle. Right atrium, left atrium. This is now your pulmonary artery. This is your aorta. And this is your superior and inferior vena cava. But what we're going to discuss in detail is yung layers ng heart mo. So yung layers niya, merong tatlo. Epicardium, myocardium, and your endocardium. So endocardium, yung pinaka nasa loob na layer. Yung nasa gitna niya is your myocardium, which contains now your muscle. And then the one covering it is your epicardium. Okay. Nasa labas, yung coronary arteries mo. Okay. So yung flow ng dugo is from outside papunta sa loob. Alright. So it means that kapag na-block yung supply dito, for example dito, no, yung coronary arteries mo, wala nang dugo na pumapasok dito, syempre, sinong maunang mamamatay? Maunang mamamatay yung pinakamalayo kasi siya yung pinakawalang umaabot na dugo. Okay, for example, yung hose. Laruin mo yung hose, yung lalagay mo yung kamay mo tapos papanipisin mo. Okay? Di ba mataas yung pressure nun? Tapos malayo yung aabutan. I-release mo yun. Di ba? Kukunti na yung aabutan ng dugo. Parang ganun din dito. Kapag wala na yung hose, kapag na-turn off po yung tubig, sinong unang mamamatay? Yung pinakamalayo. Kasi yung mga nandito sa malapit dun sa blood vessel, dun sa coronary artery, medyo may supply pa yan kasi syempre meron pang natira na dugo dun sa blood vessel, di ba? Pero technically, yung pinakamalayo muna dun sa wall mo, which is your endocardium, that is the one that dies first. That is why you have your subendocardial injury. When you read later on, when you watch later on the video on ST elevation, may explain to ng maigi. Pero suffice to know at this point, na kapag yung endocardium pa lang, at saka yung immediately after na, which is subendocardium, ang may tama, ang nasira, you can have your non-ST elevation MI. And how does it reflect? Bumababa yung ST segment mo. Okay? Nasa baba. Wala lang ako picture. Pero basta. Imagine nyo na lang na yung opposite nito. ST segment, nasa baba. Kapag nasa baba yan, alam mo na that is your subendocardial injury. Yung injury mo nasa pinakamalalayong parts pa lang. Pero kapag yung buong muscle wall mo, or that's what you call your transmural injury, happens, you will now have your ST segment elevation. Okay, anong tatandaan? For ST segment elevation, you have transmural injury or infarct. Ibig sabihin, yung buong wall ng muscle mo, sira. Pero pag may subendocardial injury, you can have your non-ST segment elevation. Yung pinakamalalayong part lang from the wall ang may sira, hindi pa yung buo. Okay. That's why you only have your ST depression. Okay. Now, what are the diagnostics? Siyempre, ECG, cardiac biomarkers, pwede rin cardiac imaging. Cardiac imaging, mag-angiogram ka. Tignan mo, mag-insert ka ng dye sa puso. Makikita mo na kagad kung saan yung mga blood vessels na may bara. Okay. Management. Ano yung mga importanteng malaman natin sa management? Control of chest pain by giving your morphine kapag talagang malala. And ito yung isa sa mga pinaka-importante. Identify candidates for reperfusion. PCI or thrombolysis. PCI, percutaneous coronary intervention. Ito yung specialized institutions lang ang nag-offer ng PCI. So, ang ginagawa nila, kung ito yung blood vessel, naglalagay sila ng stent para paluwangin. Okay? Stent para paluwangin yung blood vessel na yun para ma-regain yung blood flow. Pero, ano ang tatandaan ninyo? kina-qualify kung sino yung candidates for reperfusion. Anong ibig sabihin yan? Lahat ba ng inaatake sa puso, lahat ng may ST segment elevation, um, nilalagyan ng stent? Hindi. Bakit? When your heart muscle or your, yeah, when your heart muscle undergoes your infarct, it's only a matter of time before the damage is irreversible. So, for example, ang golden rule dito is less than 60 minutes, less than 90 minutes. Okay. From diagnosis, pag na-diagnose mo ngayon, ang pasyente, na-diagnose mo na may ST segment elevation, oh, okay, forward mo sa specialist institution. For example, nilagay mo dun sa pinunta mo, malapit ka, for example, nasa Manila ka, katabi mo lang yung ospital, okay, na nag-o-offer ng St. Luke's, for example, nag-o-offer ng PCI. Dinala mo kagad, okay, candidate siya for PCI kasi less than 90 minutes from diagnosis to the opening time kung kailan binuksan yung puso at nilagyan yung stent. Pero, if more than that, for example, nandito ka sa Abra, St. Luke's, so ilang oras ba ang St. Luke's? Ilang oras, di ba? 90 minutes lang ang qualifier natin. So, hindi siya qualified. Bakit? Mainly bakit? So, after that time, 90 minutes, as the time goes by, namamatay na talaga yung heart muscle. So, kahit bigyan mo ng dugo, yung patay na, hindi na yan mabubuhay. Yun yung point. Kaya dapat, kapag ka-diagnose mo ng ST segment elevation, i-offer mo na sila for reperfusion or thrombolysis. Otherwise, kapag natagalan pa yan, kapag matagal na yan, well, kahit tibagin mo yung thrombus, kahit bigyan mo ng stent, hindi na mabubuhay yung heart muscle. Okay. So, basically the same ang ating management. Ano lang ang dinadagdag natin? Well, nagdadagdag tayo ng additional na antiplatelets, which is your clopidogrel. And of course, your management is mainly, sinabi natin kanina, PCI or thrombolysis. Okay. So, well, I think that is the main points for your acute coronary syndrome and then your ischemic heart diseases. So, recap lang. Ischemic heart disease, you have your, what? Two main branches, two main classifications. You have your chronic stable angina and then your acute coronary syndrome. Yung acute coronary syndrome, meron siya ulit dalawa. ST segment elevation and non-ST segment elevation ACS. Your non-ST segment elevation STS, meron ulit dalawa. Meron yung unstable angina and your what? Non-ST segment elevation MI. All right. So I hope you have learned, you understood our discussion. And later on, dapat masagot nyo yung activity, this one. Okay, so anong gagawin nyo lang naman sa activity? Lalagay nyo yung symptoms, duration, response to nitrates, biomarkers, and characteristic ECG findings. Okay, so biomarkers. Ano bang sinabi natin? Biomarkers is TROP-T, TROP-I, CKMB, pero hindi yun yung mga kailangan nyo ilagay. Ang gusto ko lang na makita dito is positive or negative. Positive, negative, positive, negative. Or ECG findings. May ST elevation ba? May ST segment depression? Positive, negative. Ganun lang. Symptoms, chest pain. Duration, ilang minutes. Yun lang. Alright, and then you will pass that on Monday before you get your next module. Alright? So I guess that's it for the lecture for today. And you can just contact me anytime until this afternoon, anytime within our time period, if you need more clarifications. I suggest that you would watch the videos based on the QR codes that I have posted in your module. Okay? And happy aral. Thank you very much.